May I request Dr. Taraprasad Das to make his presentation on challenges to manage retinal diseases in India.
They may need to switch to presentation.
Oh, there I go. Good morning. Thanks, Mona, for accommodating me. Welcome, team and friends, to APO AIOS Delhi.
Sir, are your slides up?
Okay,
Dr.
my slides
Taraprasad
coming
Das'
here.
slides.
Slides are here, but not there, though. It is here, but not there. Thank you. When I designed this session with Mona and Neil Bressler, one interesting idea came out that how do you really manage retinal disease, because in Asia Pacific region, China and India are the larger countries, so the larger burden. So we said, let's look at it. Are you really prepared or not prepared? How do you look at India? India is 29 states and 8 union territories with a 1.4 billion people habitating in a over 3,800 square kilometers and with a population density of 488 per square kilometer. We are 36% or 37% urban and little less than 50% are female population. Good part is that we are the fifth largest economy of the world with 3.5 trillion US dollar economy. We had a world share of, which is world share of 3.5% or so. Our GDP growth is 8% and per capita GDP is 2481 US dollars. But when I look at this burden of blindness in India, I look at it two different ways. One, what is the country-specific blindness, India-specific blindness, and then India being a large country from Kashmir to down south to Kanyakumari. I look at that economic transition level of, because India is not actually one state, it is a larger federation of 29 states and 8 union territories. How to define ETL, epidemiological transition level? It is a all age disability adjusted life years over the communicable maternal neonatal nutritional diseases. We will divide them. Low ETL is bad, high ETL is better. High ETL means higher non-communicable diseases and higher proportion of injury. And lower ETL means higher communicable diseases and lower burden of injury. We divide the country by that way. And before they talk about the Delhi stands for the measure of number of years lived with health or with disease, and we compare that and we find out how people are living early and dying early. The prevalence of blindness over last decade, as measured in India by large epidemiological studies in 2010 and 2019, the good part is that both visual impairment and blindness reduced by nearly half time, from 5.3 to 2.5 of visual impairment and 0.68 to 0.36 of prevalence of blindness. And how to define that? We define as blindness as just like WHO, less than 2,400, and visual impairment divided into severe, moderate, and early visual impairment. Also important, look at the functional low vision, which is visual acuity of 20/60 to light perception with the visual field of less than 10 degree. Very important for navigational, for quality of life. But divide that also into by gender, we find that in any segment of the blindness or visual impairment, all segment of visual impairment, female gender have a higher burden of blindness, visual impairment than the male gender. Then divided at the ETL, economical transition, epidemiological transition zone, if you divide into the color coded here, green is high and the blue and cyan is middle and the red is low. And the whole country is not one transition zone. So based on that, you find out that blindness and visual impairment profiles are different. Example, in high ETL states, down south in Karnataka and over here, if pointer goes, yes. In the Kerala and Tamil Nadu example, high ETL, there are blindness profile is 1.43% compared to low ETL, which is over 1.74%. So look at the visual impairment. Similarly, high ETL have got a comparatively lower visual impairment than the higher ETL states in the country. So 6 key factors in retinal care in India that I look at it: the complexities of care, the disease prevalence, geographic distribution in the country, patient volume, health infrastructure, and the training and expertise of the people. all retina care requires a specialized care. Whether it's a diagnostic, obviously it is more expensive than other diseases, but surgery requires higher skills, that means higher training. Look at the disease prevalence, and this is what it shows in national average. Compared to national average, the blindness or visual impairment is much higher, 21.4 times higher with blindness and retinal diseases in India compared to the national average, of which includes cataract, refractive error, etc. Similarly, on the refractive error. I've taken diabetes as a model to find out how they distribute in the country. We find that they are not evenly distributed. There's some states are low, some states are high. Example, high ETL states like Kerala and Tamil Nadu, higher blindness, diabetes prevalence compared to this. Not only that, we look at the urban and rural, they're also different. That means at least prevalence of diabetes is different in the country, both in rural and urban area, between the high and low ETL states. Look at this. People over 50 in India between the census of 2021, 138 million. We look at translate into actual number, there are 24.86 million people who are blind or visually impaired of retinal diseases, and of which 43% are blind and remaining are visually impaired. There are 15, as of the last count of a couple of months ago, it was 1,500 retina specialists in the country registered in our society, Retinal Society India. If you divide them into 285 working days, removing all the Sundays and holidays, then the burden of DR, AMD calculator and other diseases requires 70 people a day you would examine, 58 for a direct care and 12 for review patients. If you look at the distribution of the care in India, obviously in all specialties, the private service is little better off. 65% of care in India is given by the private organizations, and remaining by the public health services. Somehow other public services are not as efficient as private services right now in the country, at least for diabetic retinopathy care. If you divide those areas into availability of retina specialists divided by the ETL is shown here, but this will be a little confusing slide to calculate, don't want to calculate it. But then one example, a small state like high ETL of Kerala has got 78 people, and the larger ones like this has got a comparatively less number of people. I divide that into the number of people available. The ideal in the world by WHO standard is it should be 10 retina specialists per million people. Doesn't matter whether high or low ETL in India, there are less people, and obviously higher in the higher ETL states compared to lower ETL states. So 5 solutions, from capacity building to policy change. Let's look at the capacity building. Years ago, 2015, I was working with IAPV. We had a meeting in Nepal to find out what is the world or Southeast Asia ready for take care of the sustainable development goals. At that time, we said that capacity building, human resource for eye health distribution, eye health, and then poverty alleviation, 3 important requirements in 2015. That has not changed in 2020 when you publish again. Then we said that investment in structured eye care delivery is very important, so to improve the workforce, as applicable to most part of Southeast Asia, so also for India. That is why WHO came out with a system how to engage from the community to tertiary care, and they call it integrated people-centered eye care, and where we can suggest for retina care, at least we can talk about. Can I continue for a couple of minutes?
Continue. Continue.
How to do advocacy in the community level from general ophthalmology to a specialist ophthalmology retina specialist in the country. So supposing we have this number, actual number, we had a 1.38 million general physicians and 2,800 general ophthalmologists. If you engage them for fundus screening for general ophthalmologists, so general physicians and 28,000 people for laser or intravitreal injection, then the requirement is that less than 1 person of diabetes at least have to examine a day for the fundus photography, and around 3 people who do an injection or laser, much easier compared to taking care only retina specialists. So my recommendation has been always that this thing can be done by somebody else. Retina surgeons can do surgery or higher things. Luckily, technology developing in India, we have both table-mounted and handheld small portable fundus camera, which can take photograph in non-mediatic fundus cameras. That is being has a huge, good amount of sensitivity, specificity, and negative predictive values. So we have published many times, and so also for the AMD. Last few months ago, the government of Kerala, for the first time in India, actually had a huge policy change. Policy change that it launched actually a non-mediatic camera from the community to the tertiary level, so that at least diabetes and AMD can be taken care of. This, supposing other states of India start copying this idea, then most probably will be a huge policy change for the country to handle all the retinal problems. So problems are high prevalence, low human resource for eye health, unequal distribution, high cost of care because of growing population, aging population, and lifestyle changes, increasing urbanization. But then solution also lies that task shifting, task sharing, use of new technology, including artificial intelligence, and adapting the newer model of health delivery like universal health system, health policy change, reduce cost of care and advocacy. Thank you very much.
Thank you, Dr. Das.
Since I have to go, Muna, any question, then I will have to answer now because I have to run to another, another place.
Since the talks are very different, we'll be having a couple of questions after each talk. So does anyone have any question for Dr. Das? Otherwise, I have a question bar comment. Anyone has a question?
Okay.
Dr. Das,
I was clear. Okay, no, I was
I
not
have
clear.
a question for you. We always talk about the burden for the doctors in diabetic retinopathy screening, and I've always noticed we say, but doctors really don't seem to be that busy. The question is the patient sent or not?
Say
Because if the question is, does the patient actually come to the doctor? It's not that the doctor
okay.
is so
Now, that
busy.
is why the
most of the
integrated
time.
people-centered care, you go to the community is important. Supposing community do advocacy that you have to go to a doctor, and then that they climb up to the primary to secondary level, then most probably will happen. It doesn't happen in all this. Example, Kerala, everybody goes to the doctor, not happen every. So we require a lot of advocacy, but then also we, the retina specialists all sitting here, must shun away the idea that only we have to treat everybody.
Yeah.
And don't have to treat everybody. Example, how many ophthalmologists today actually do a refraction? It was once upon a time, it was bread and butter. Similarly, we have to think an idea that how do we distribute people, because with 101 million people diabetes in the country, 136 million undiagnosed diabetes, 236 million. So how do you handle this? So I think it's a question of time when we'll go to doctor. Supposing like we have done that, go to the, instead of building a large tertiary hospital, go to a secondary, primary hospital, then go closer to people. Most probably this is possible, maybe in next 10 years' time.
Yeah, and probably just one line from the person who prescribes the medicine to the patient for diabetes, go see an eye doctor. So that itself transfers a little bit of